Okay, so now on to our today's program. We'd like to welcome Dr. Rich Dhyanchand and Dr. Lauren Prister of UW-Platteville. They're going to be giving a COVID-19 update, telling us about the latest on vaccines, variants, and the impact of our lives. Please welcome our guests.
It's nice to see friendly and familiar faces, so thank you. I'm just going to start by just introducing us again, and then and each other, but we want this to be like super informal. So we do have some prepared slides that we put together to kind of highlight certain things and honestly review certain things. A little bit of a refresher is always kind of nice. But then the goal is really to make it about your questions. Yeah, we have additional slides that we've prepared that we can hit on if you guys, don't have as many specific questions. But we really want this to be tailored to what you guys are concerned about or questioning, and we'll use whatever expertise we have to try to answer those things. So as to who we are and what we do, I'll introduce myself first, and then Lauren. So I have been at UW-Platteville for a dozen years now. I guess 12 years, living in Lancaster for almost 10 years now. And so I have about 15 years teaching at the college level. My background educationally is that I was a physician by education, but never practiced. I worked for Pfizer for a while. I did some research at UW-Madison for a while. And prior to med school, did some public health stuff with some epidemiology and biostatistics training at the University of Illinois Chicago. Most of what I do now is in the realm of healthcare. Teaching classes like anatomy, physiology, human gross anatomy, or cadaver stuff that we do down there, some pathology, histology, and a lot of advising of students that want to go into healthcare careers. And then broader in healthcare stuff, I have developed a very strong interest in particular, like rural healthcare. Serving on the board of the hospital here in town at the moment, but also for almost 8 years been involved with something called the Scenic Rivers Area Health Education Center. Wisconsin has a really big area health education center, AHEC, and our region is Scenic Rivers, and I'm currently president of our little region here. So care a lot about rural healthcare and a lot about rural healthcare education, but which is kind of a unique and new position for me coming from Rockford, Illinois, where it's a bigger city, but always been around healthcare, and that's something that I care a lot about. So I'm not an expert on all things COVID, but I have learned that I think I pay attention to things more than some folks do, and also have just a little bit more of maybe a critical eye for certain things, just that comes from having gone through a certain amount of training. So I also want to introduce Lauren Priester. Lauren is newer to our department. She signed her contract to come to UW-Platteville like the day before the world shut down. And came to us from a year at Northern Michigan University. I was the chair of the search that landed her. But she trained at Michigan State University for undergrad from a small town in Michigan, Ludington, right? Mm-hmm. Yeah, and so go Spartans. And then she did her PhD at Northwestern, mostly at the medical school, really. And her world is kind of virology, microbiology. So she is a virologist by training, sort of. What else am I missing about you?
That's mostly, so it's my second year here teaching. I live in Dubuque, so it's close by.
Yeah, so she and her husband and newborn Jude live down in Dubuque, and Jude's over with Emily and the kids right now. She had that first year virtual COVID weird of teaching, but she's been a fantastic addition to our department. She also is involved with a lot of advising of healthcare students, and especially in the physical therapy, chiropractic world is kind of where she's stepped in. So that's kind of what we are here to do, and we're, so again, it's mostly about questions, but I'm gonna let Lauren kind of kick things off by talking a little bit about the virus, and I think this should work.
Okay, let's try that.
There you go.
It does.
Okay. So as Rich said, I got my PhD in microbiology, so like the biology of viruses, bacteria, the immune system, that kind of is the stuff I learned a lot about. This is a little bit of a complicated figure, but what I wanted to talk about and just introduce is the virus itself. This is the virus, it's called SARS-CoV-2. It causes the disease COVID-19. And this virus is made of what's called RNA, which every cell in our body uses RNA to make all the little proteins that make up and do most of the things in all of our cells. All of our genes are made up of DNA, but some viruses can use RNA instead. And importantly, I wanted to point out, so this is a little virus, it's got a genome just like we do, and then it's got an outer coating and a protein on the outside called spike. The spike protein is super important for this virus to stick to the cells in our body and be able to infect us and cause disease. And so this spike protein is the focus of a lot of COVID studies, and this is what we're kind of looking at when we want to stop an infection. So, oops, going really fast. When we started thinking about, we meaning scientists, I was not involved, but scientists started thinking about how we wanted to stop an infection and maybe prevent infections with a vaccine. They focused in on, going real fast, this spike protein, because this is the protein that lets the cell, or lets the virus get into our cells. So if we cover these up, we wouldn't get infected. So the scientists developed a vaccine with little instructions made of RNA to make the spike protein. And so the vaccine itself is just these little, very unstable instructions that get into our cells and then fall apart in about 30 minutes. And then our cells make little spike proteins. And when our cells make these little spike proteins, our body says, hey, wait a second, I've never seen this before. Let's make an immune response and target this little protein. So that's what they do. All of our different immune cells get involved and start to make what are called antibodies, which are basically these other proteins that can cover up a virus. And we make antibodies against this spike protein, and therefore we are able to cover up the virus so it can't stick to any of our cells, and we won't get sick. That's called neutralization, so it neutralizes that virus, basically. And this is what is called new technology because a lot of our vaccines use other forms of maybe a weakened virus, maybe they use a weakened bacteria. Sometimes you can just like boil a bacteria and then it's dead and you can use that as a vaccine. This is the first time we've widely distributed RNA vaccine. However, we've been working and studying RNA vaccines since the 80s. So scientists have developed vaccines, hopefully doing the same thing for Ebola. There are a couple others, I don't remember all of them, but they've been doing trials on RNA vaccines well before we started this COVID one. The nice thing about the development of this vaccine is it was super fast. The outbreak started, in January and kind of hit its peak a couple months later when it came to the US and everything shut down. And then we were able to get this vaccine out really fast because it's really easy for companies to just synthesize these little RNAs And we can make them specific for whatever we want to target. And so it was really a great way for us to quickly make a vaccine. And because this vaccine is so simple, it just has RNA and then it has basically a little like oil droplet around it so that it protects it so it can get into our body in the first place. Because that RNA is so unstable and falls apart really fast. We knew that this type of vaccine would be pretty quick to get to clinical trials and then people, and then thankfully got to, arms almost just a year later. So this is the vaccine that is most common, so the Pfizer and the Moderna vaccines are of this type. There is a third vaccine that is used in the United States that is less common because Pfizer and Moderna just made a bunch and got theirs out first, basically. The Johnson & Johnson did something similar, but they made a different kind of virus as kind of a packaging. And I kind of think of this as a little wooden Trojan horse. And they put DNA inside of it. The Trojan horse is not a real horse, can't do anything. This is not a real virus that can do anything. It just helps protect that DNA and get into our bodies. The DNA, again, makes that spike protein. Our immune system makes a response to the spike protein and protects us from the virus. So those are kind of the intro things about the vaccines.
What happens with that DNA with regards to the J&J? I mean,
What happens?
How quickly is it degraded, or
It would be less. I don't know how long DNA would survive. It would depend on probably what cells it gets into, but it works. We have used vaccines like this much more.
Right.
There are other vaccines that have this basically inactive virus with DNA inside. I'll have to look up which ones they are. But yeah, it's more stable, but still, we've never found any incidents of like DNA from some sort of vaccine getting into a cell and then inserting itself into that cell's DNA or the genome or anything like that, because I know that's something everyone would be concerned about, but we haven't found any incidents of that, and it's not possible to do that with RNA because RNA is different than DNA, so it can't just stick itself in our genome because it's not the same molecule, basically.
One thing I've wondered is, what does Moderna have that's different in theirs to increase the stability and that it doesn't have to be at the -70 freezers, versus Pfizer's?
Yeah.
Is there just something different in the envelope, or?
That's what I understand, is it has something to do with this outside lipid area, but I don't. They also have updated their storage abilities, I believe, that it's like long-term stored at that really cold temperature, but short-term it can be stored longer in freezers/fridges. But they are also, the thing that I'm not sure, if you start out one way when you're making something, I don't know how long it took them to like reevaluate the storage capabilities. And if you know it works and you can get it out and keep it at -70, they might not have reassessed until later the storage.
And that's kind of the -70 is kind of the default when you're working with these
Yes.
viruses.
Yes.
Yeah.
So I'm sure when they made it, that's pretty easy for them, but obviously not for most healthcare facilities.
Could you also talk a little bit about the efficacy and what those numbers actually mean?
Yeah, so those numbers were talked about a lot, and that's something that all vaccines that's the number you want to know. How effective is it at X? And so you can say efficacy is, for these and these numbers, 95%, efficacy means preventing disease. So a 95% efficacy would mean that out of 20 people, one person could still get sick after getting this vaccine, because that's 5%. And so that's something that, I know in the news we see that a lot, breakthrough infections, and obviously those aren't great, but 95% efficacy is really good for a vaccine. The threshold that the FDA put out when everyone was rushing to make vaccines was 50%. And that's what the flu is. And I still think the flu vaccine is great, because if you have a 50% chance of not having the flu, that's great, because the flu is a really terrible disease to have. So 95%, and this one's basically 95%, was a really great first shot at these vaccines, but it does mean that, 1 in 20 people exposed to this virus can still get sick. The thing that this number doesn't capture is the severity. So with a vaccine, you are much less likely to have severe disease, because your immune system already knows how to start fighting this. And it's the same with some other diseases we have, where if you get a disease a second time, it's much more mild than the first time you get it, because your immune system can start fighting it right away. Versus the first time you get sick, your immune system has to learn how to fight the disease, and it takes a week or two to build up those antibodies and those immune cells that can fight off the disease. The efficacy of the Johnson & Johnson is lower, but I have read that now they're bringing up the idea of boosters. Johnson & Johnson is now recommended to get boosters, and you can also mix and match the vaccines. I think that will bring up the efficacy of this higher, because it's currently, as a one shot, not giving you those 2 doses to help your immune system make a bigger response. Because each time you get a shot, your immune system kind of almost, sometimes it's like 10 to 100-fold increases its response. And we get boosters for tons of vaccines. My 4-month-old just got a bunch of new vaccines, and they're usually 2, 3, 4-part series of vaccines. That's sometimes as much as it takes to get a really good immune response.
Yeah, I'm seeing some data that J&J, they're making suggestions that maybe it should have been a 2-shot, vaccine from an efficacy kind of point of view, and from a maintenance point of view with regards to the boosters, which we've kind of been looking into some of that as well. And you've been hearing a lot about boosters, in the last, honestly, just in the last week for sure. But the idea that the J&J, you can correct me if I'm speaking on this, but with J&J, the idea that if somebody has had some adverse events associated with it, specifically like a young woman that may have had the severe clotting issue that came up with the J&J vaccine, or some incident of the myocarditis, if that's a concern, these are extremely rare side effect profile things. But the idea of switching to one of the mRNA vaccines, and for all intents and purposes, maybe think of these as the same, with Pfizer, Moderna, but some of the studies that I saw, boosting Moderna with Moderna seems to have a stronger benefit maybe than Moderna with Pfizer, Pfizer with Pfizer, but it's the waning of these ones, maybe, if you look at when you had that last dose, I think what I saw was in the 6 to 8 month range. So 6 months is how long the effectiveness of some of these messenger RNA viruses seem to be, which are actually comparable to the natural immunity piece.
Yeah.
So,
Your antibodies are pretty high for about 6 months after you get exposed to something.
yeah, and so, about 6 months, whereas J&J was more like 2 months. And so, breakthrough infections are coming as, as you're losing some of that protection. And so, I think all of us that are vaccinated, myself included, it'd be nice to get to that place where I could, I can get the booster, I think, anytime. I think one of the big factors in getting the booster is availability. Like what is available, where can you get it, and some of the, I think we were all present when they were rolling stuff out, and where they were rolling it out, what they had. My wife and I got vaccinated within an hour of each other at the same facility, but she had Pfizer, I had Moderna. It just, a lot of it is what they were doing at the time.
So are they talking about mixing and matching because of that? Because maybe when you get your booster, they'll have Moderna and you had Pfizer?
That, I'm sure that's a factor. One of the, you can mention the one thing, like the Mugshot kind of thing that we're.
Yeah.
The
So I think the thing that they have studied so far is that Johnson & Johnson, then getting one of these gives you almost like a better immunity because it's giving you a slightly different version of that spike protein, and so your immune system can make even more antibodies that recognize slightly different parts of the protein. And so the metaphor that we like to use is like it's giving the mugshots of the perpetrator, and your immune system is the police looking for them. And so the more profiles of that spike protein you can look at, your immune system knows what to look for, the stronger your response is, because you have kind of the most protection you can get from your.
So really, if you had a Johnson & Johnson and you got Moderna, you'd be, maybe
Yeah.
covered a little bit better.
Yes.
Okay.
And it's the one shot of Pfizer and Moderna, the efficacies were around, I believe, 60-some%. So I think, Johnson & Johnson could have been 2 shots, but it's still, all of these met a good over 50% threshold right at the beginning.
I'm not in the room where Johnson & Johnson is trying to make these decisions about how to roll out a vaccine, but I have been in the room for other, pharmaceutical company discussions, and, I'm sure they're trying to tap a market of people that only wants one shot. And when the bar is set at 50% and you're at 72%, you're beating that. And so, I'm not saying that they don't care about the healthcare piece. I'm sure they care about the protection and the healthcare piece, but 95%, those are crazy
Those are
high,
so
numbers. I rarely have a student perform like that on one of my tests. Those are, so 72%, if that was the first one that came out, if J&J was the first one that came out at 72%, we'd all be like, whoa, that's crazy good, right? But that wasn't the first one that came out, and then all of a sudden the bar is set, in a place where you're like, oh, and so, I'm sure that they're trying to tap a different market on some level, right? So it is people who are, needle averse or just only want to go for one shot, or, and the thing is with these coronaviruses, it's always been hard to make, vaccines against coronaviruses because of that, the rate at which they can modify and change. I don't know, that metaphor that I always like to, it's like when, like, say I got sick and I gave it to, to Mike and gave it to Cindy, and, the modifications that happen just in like 2, it's a copier, but it's not a very good copier. It's a bad copier. So there are some changes that can happen, and those changes always don't lead to, the Delta variant, right? Sometimes they just make it inert, and it maybe doesn't cause as much illness in a person, and sometimes it can be a lot worse. So,
Or maybe it doesn't become that much more contagious, maybe it becomes less
yeah,
contagious when it dies out.
Yeah,
Yeah.
you know, you know, and there's so much that we don't know. You know, definitely so much that I don't know. But but there's so much that scientists that are spending time on this are learning, and and I have a lot of faith in the ability of the people that have been working on this for a long period of time to kind of further that process. Maybe I shouldn't be asking questions because I'm supposed to be doing this.
We're a
But-
small group.
yeah.
Yeah.
But like the natural immunity piece, and then like natural immunity plus adding a vaccine seems to be giving some pretty good protection.
Really good protection.
Yeah, almost like you're getting some super kind of powers. But how did that natural immunity affect you? How did you arrive at that? I have a neighbor who was not vaccinated, got sick, had to get admitted, but was home for almost 2 weeks, missing work, until he was admitted, spent almost 2 weeks in the hospital, discharged with oxygen, that he thankfully didn't need to use, got a pneumonia the next week, is working now full-time 6 to 8 weeks later, but we used to walk dogs together, and he's not able to climb the hills as easily as he used to. He'll be able to get a vaccine, which he, I think, wants to now, sometime in January. He will have some very good protection, according to the data that we're seeing, but he still has a significant amount of respiratory compromise.
He's got some
Yeah.
lasting.
And so it's, some people didn't get that sick when they got it, and it's, but these are,
I think that's my vaccine spiel, and it kind of leads into your
Yeah.
section you wanted to talk about.
Yeah, so one thing that, there's two things that I kind of wanted to mention, and this is actually quite good because you guys are asking questions as we're going along, which is what we want. This is a slide that I, stolen, but I like it because, it highlights, your vaccines, right in here, right? But I think all these different layers of protection that we utilize and that we're trying to do as a society and as individuals kind of fit in here, but the cool thing with the Swiss cheese metaphor is that none of them is perfect, right? They all have, these gaps in them, these holes in them, but when you put extra layers on that are imperfect, you still get a cumulative benefit that is there. So when we look at the shared responsibilities that we as a community can do, that's where, now that we have vaccines, the more people that get vaccinated, the less likelihood of that spread kind of making its way to more vulnerable people in the population is great. Doing stuff, outdoors, using air filtration, better ventilation systems, anything, the testing piece is really important. I've been increasingly frustrated at out of the gate, how poor the testing was, meaning that we didn't have good testing. It doesn't really benefit. I'm a really, really slow grader when it comes to my classes, borderline awful. And when I don't give quick feedback to my students, what can they do with that? I'm, it's you'd almost rather not give the assignment or, then, but if we don't get good feedback with the testing and quickly with the testing that we're doing, you can't really alter behavior in the way that you maybe need to. And so, I'm still getting tested weekly. I'm working on campus around, kids. We're masked all the time at the university. We're teaching like this, but, it looks like our vaccination rates are not fantastic.
of the students reporting, we're still less than 50%. And so it's not, it's not great. And so, but having good testing is important, and then, actually working with the health department and people on the whole contact tracing piece and quarantining and isolating when you need to. All those things that we as a community can do to help reduce the spread. When you look at the personal responsibility piece, there's a lot of stuff that's in here that we all have come to know as being kind of more common things these days. Not going into majorly crowded places, not touching your face, hand hygiene, cough etiquette, and so on. The mask wearing for sure, and then social distancing. And it's at the end of the day, it's all about mitigating spread, all about reducing risk. Might I go into a restaurant, and be eating dinner around people I don't know, and take my, we went out to eat last night. We had, and we, not eating through a mask or anything like that, but we, it's not something we're doing 4 times a day or 3 times a day. It's, I'm doing it few and far between. We're reducing the risk by the way that we're doing it, and the cool thing about this is we've learned a lot. There are some things that aren't on here that we thought were really important, 2 years ago. For example, the cleaning of surfaces and stuff like that. It seems to be respiratory droplets, air spread is how this is happening a lot more frequently. Yeah, it's possible that if I were to cough on the table here and Rob were to then rub his hand on that and rub it on his face, that could increase the risk of something. But it seems like that's, the risk and the need to wipe down surfaces is, all but gone away. And we've learned, right? And so those are things. So I did want to mention this because, the better we can do at kind of just making a lot of these just part of the way that we live, and in a lot of ways, the better we're off we are. But we also can start removing some of these, things as well. A higher vaccinated population means, more ease and comfort in gathering in large groups. I've been, this summer I went to Boston for a little over a week, and then we also went to Florida, for about a week. And 2 very, very different places that we were with regards to, vaccination rates. When we were in Newton, Massachusetts, the vaccination rates listed there are, 90+%, right? And culturally, wearing the masks was okay. Where we were in Florida, very, very different. We behaved very differently as a result also. So, it's those are some things to kind of think about, okay? The only other thing that I wanted to mention is something that's kind of been a little bit of a frustration to me, and maybe is something that all of you are familiar with, but it's related to just science in general and what the nature of science is. Now, this is not a COVID specific piece that I'm addressing here, but I wanted to specifically talk about one phrase, but I see, I try to spend not a lot of time on social media. If those of you, are, social media, friends of mine, you probably see a lot of, pictures of my kids and dog, but, I do see what other people are doing, and from a scientific point of view, I do see that there's a lot of misunderstandings about what the role of science is and what science is. So people tend to think these things, and I'm using people in quotes here. I see a lot of, general public or people who just, maybe don't deal with this daily, that science is in absolutes. They see it as this binary thing. Everything is an absolute. It's unwavering, that there's a tremendous amount of biases that are associated with it, that it's motivated by, the trying to have a certain outcome or finances, that it's an individual's findings, okay, and then an individual's belief system, and a lot of people go about perpetuating these issues. Now, what good science is and should be, is that it should be, and this is a really important point that I'm going to hit on the next slide, but presented in what we call degrees of certainty, okay? And I'll come back to what degrees of certainty means. But is that it is in a constant state of flux. It's not this law, or it's not an absolute. Science should be free of bias. Science should be based on things happening in the physical world. Not just what one scientist is doing, but what many scientists are kind of replicating and doing. And then also well-defined, testable, measurable, repeatable. You know, we teach our students these things. You know, this is a slide that I have used for like an introductory. I used to use it in BioQuest. So this is like for our freshman biology students. Okay, talking about what the nature of science is. Okay, now when we hit on this bit of degrees of certainty, I think there's this real frustration that science doesn't work. It's not about 100%, and we shouldn't, you know, you're not striving for this 100% thing. It should be stated. So lots of times I get frustrated with the media when it presents data. It presents it as, you know, and I'm using this phrase media, you know, this term really broadly, right? But it's just easy to report things that way, and so sometimes it just gets thrown out there. And so the thing is, you know, with every new test, new fact, and review of current literatures, you might support some sort of theory, and then degrees of certainty increase over time. So what do I mean by that? If we have extremes here of this is one viewpoint, and at the other side is another viewpoint. You know, back in the day, let's think, I don't know, there's some guys trying to figure out what gravity is, you know, and how do you measure gravity? Oddly, or, you know, still remember, minus 9.8 meters per second squared. So I'm sure there were anti-gravity people that were out there, you know, or debate about how to quantify gravity. But over time, you repeat it, and you repeat it, and you get further and further down here where it's minus 9.8 meters per second squared. Now, if we want to go out and refute that and come up with a study that says, you know, gravity is different, we might be able to show that for some reason. Okay, maybe we're showing it slightly different. That doesn't mean that now we're over here. Okay, we're not back to that other side now. What we've done is maybe, you know, we're a little less sure of things. Okay, you know, and so the idea is that, you know, we have a breadth of data and a breadth of information that has taken sometimes years, even decades, to kind of, you know, create, and, you know, a one-off study, or, you know, certain researchers that are trying to, you know, maybe have a different idea of how it is. You know, they're trying to refute some of that. It becomes difficult to do that with, you know, in a short amount of time. So, you know, waiting for 100% agreement is really not really, you know, very sensible. Okay. You know, and I mentioned this with regards to mask wearing. I mean, there's been a lot of that going on in the community about wearing masks. Wisconsin has the stance that it does. You know, I've attended a lot of the school board meetings where people are discussing this. And I've had this discussion with some people in the community, healthcare people in the community who have different viewpoints than I do about, you know, masks. And I just kind of said, you know, forget about COVID specifically. There's a tremendous amount of data that wearing masks reduces the spread of respiratory illness. You know, it's been done in healthcare settings for generations. And then a study comes out that says, you know, there's some negative impact associated with that, or it doesn't work as effectively, or something like that. And that one study doesn't put us here. Okay, and there's, you know, I just think that there's, you know, I've found myself getting increasingly frustrated with people speaking about scientific data in absolutes and it should never be spoken about in that way. You know, it's all about learning in this process, and with a novel virus like what we're dealing with, there's a lot that we're learning, you know, regularly. I'm amazed at my friends that are, like so on top of this stuff, you know, the things that they seem to know, you know, it is, you know, like, oh, I didn't know that yet, you know, but they're a little bit more in the trenches with some of this stuff than I am out here in Southwest Wisconsin. So, yeah, and last thing I added on here is that, you know, just the idea of doubt and kind of throwing shade on, so to speak, you know, from people, it actually creates sometimes, you know, I'm all about like questioning things. I think that's the scientific process, right? It's about asking questions, but it's also about listening to the answers. And then when you hear the answers, how do you change or modify what you're doing? And simply just creating doubt, which is what I think I see some individuals doing. It just, you know, creates a lot of inaction sometimes. So,
I think, well,
yeah.
Gil, just comparing this and the doubt and the 100% agreement among scientists, blah, blah, works for climate change too.
No, this
That
is.
there's 97% of climate experts are gaining more understanding of what is actually happening to the climate, and there may be this 2 or 3% that still say either it's not happening or it's normal or it's and so then
Yeah.
creating the doubt, which is keeping people from taking action or using that as an
So
excuse.
these slides were basically stolen from a friend of mine that was doing it with regards to, talking about this with regards to climate change.
Yeah.
You know, that's exactly, you know, the same thing. You know, I think that that's very true. And we've done an unfortunate job of equating the 97 with the 2, or with the 3%, as far as, you know, in an attempt to make it so that we need to hear you know, we need to hear like different viewpoints on this. So we'll take an extreme, you know, minority viewpoint and equate it with this other one, and then, you know, put them on the same level playing field, and it where they shouldn't be, because, you know, their viewpoints are extreme outliers. So
And it seems like some of it is fear.
yeah,
That people are afraid of climate change, and they can see it happening, but they're just afraid. And some of it is, oh, they just feel overwhelmed. It's such a huge problem. I can't do anything about it. I'm not going to worry about it. I'm just not going to do anything about it. I'm not going to think about it.
and tremendous economic interest.
And
you're talking about.
pandemic is in those same lines
Yep.
too. It's just such a huge problem that.
I mean, we work in a department where, I think we were just saying, about half of our students are, you know, healthcare, kind of, you know, healthcare / you know, small things minded, and then, you know, meaning molecular, micro, that kind of stuff. And then on the other side is like Aaron Hipschman's husband, Jeff, and, you know, the ecologists that are, you know, organismal and doing all of these, you know, and they've been trumpeting exactly what Sally's, you know, saying for quite a while, you know, that, you know, and it was like when all this stuff started happening through the pandemic, I've just come to realize, you know, I have a lot more empathy for their frustration with how people have, you know, been ignoring, you know, things that they're happening. But I think, you know, humans take more action when there is like direct personal involvement, and also, you know, when there's financial things that are at play there, sometimes that impacts their willingness to act on certain things. But yeah, it's a tough one.
The
But-
media doesn't help any.
Yeah, you know, and it's a, you know, the media is this whole big thing, right? And there's so much, you know, complexity to the way I think the media has to do these things. And you know, I think I'm glad we have media. I'm glad we have, you know, sources that can give us information. But sometimes the motives in which they're giving that information are, you know, not great, because they need likes and clicks and viewership and Nielsen ratings and all of those things in order to, because they're dependent on advertising. You know, conflict, you know, if it bleeds, it leads. You know, conflict is an important piece that they need. I'm a devotee of the PBS NewsHour. My kids, I'm sure, can sing you the theme song now. If they want to. But a lot of it is because I like the way I feel at the end of watching that. I like the things that newsroom values when they put it out there. They choose stories that aren't overly doom and gloom. And they give a lens that is a lot wider than what I see on pretty much anything else. So we do have other things to talk about. We are willing to entertain questions that you might have at this point. So, more questions, I should say. You're already doing a good job of that.
When you click on the Wisconsin and you go down to Grand County, the deaths the last few weeks have kind of gone up.
Yeah.
Like Grand County's got 116, you go to Crawford County, or Lafayette, they only have a few. Why is that?
It's a good question. I don't know. I'll be honest, I haven't followed local. I mean, I've been tracking a little bit of what's happening, but I haven't been asking the why is that happening.
Part of this, part of the population base.
Do we have more people?
Lafayette's pretty small
Yeah.
population.
Yeah, there.
Iowa County's a pretty small population, but.
Yeah, I mean, yeah. So from a there's these terms that are there's straight up deaths, right? But then you look at death rates, right? Where you're doing it like per 100,000. Some of the stuff they have on the DHS website is fantastic. They have some really good things on the DHS website where they'll turn it into like fatality rates and things like that, and you can kind of see, and then you can see what the risk is or see what the numbers are like, and it's not an absolute number, but you're getting a sense of percent of population, how affected. What other questions? I guess.
So as far as being contagious and somebody being vaccinated, is that person, like for some of the breakthrough cases, are they less contagious than somebody who wouldn't have been vaccinated? Is there any evidence one way or the other?
Yes. So I've only read, there's been a couple studies that I've read. I'm sure there's plenty more, but so when your immune system starts fighting the virus quicker, there's less virus around. So they're saying that the virus levels are kind of lower with vaccinated people. And so if you're shedding less virus, you're probably less infectious. And the duration of your sickness can be shorter, so you'd be less infectious for a shorter amount of time. There are a couple studies at least that I've seen that have looked at that, and so they're at least currently saying that breakthrough infections are not really the main part that's kind of leading the resurgence of cases since we've seen this spike kind of this fall. It's not usually the breakthrough cases that are the ones that are kind of driving this increase that we've seen. But you can still transmit the virus with a breakthrough infection, it's just less likely.
I mean, it's you've heard the phrase, I'm sure, that this spike is definitely turning into a pandemic of the unvaccinated, where it's in that unvaccinated population where we're seeing most of the hospitalizations and deaths, and we should also add to that we use the death thing a lot. Like we talk about deaths, again, sitting in a school board meeting and I hear people, using, well, no kids are dying, no kids are getting hospitalized from this sort of thing, and which is a good thing, but there is a lot of morbidity, significant amount of morbidity that comes from infections, not just with COVID, but all sorts of other illnesses that are infectious diseases. I think I actually have the slide in here. Wow, right at the very next slide, apparently. We're focusing too much on death, but there's a lot of long-term things, surrounding morbidity. When we look at this, there's lungs, there's heart, there's kidneys, there's brain issues that could happen with all of these. with COVID specifically. Like I questions that percolate through my mind are, what is the need for, say, lung transplants going to look like in 15 years?
Already.
Yeah, oh yeah, already, exactly.
So
Yeah.
how are they keeping track of that data? I mean, for a lot of people who got it, a year and a half ago, and are still suffering with some of these problems, are we tracking that? I'm assuming we are, but
I've read not well.
Yeah,
No.
I think that's the correct answer. It's we haven't done a good job of, what public health departments have been tasked with doing. Like local public health departments are very much our, front line, and then it goes to states, and states do different things than the way that maybe the federal government does. But it's like the military, or any company, there's a hierarchy of how things get there. And there's a lot of variability as to how things are done in different localities. When you underfund things like this for an extended period of time, it also decreases some of the resources and the resource allocations. There were a lot of kind of very, very wealthy kind of, tech type entrepreneurs and such that were ready to kind of, okay, we have this way that we can use, apps and different things to do stuff, and wanted to work with health departments. But health departments are using fax machines, right? So there's just no, way to communicate and work with each other. So Lauren's exactly right. I think that we
Yeah,
want to do a
I
better
thought
job.
it's been interesting, it's been interesting for me. I've since been vaccinated, and I've joined in with that app, and it's less frequent now, but they check in with me, how are you feeling? Have you had a positive COVID test? And I'm like, yeah, okay, we're creating this database
Yeah.
somewhere
Yeah,
of vaccine efficacy reactions, long-term.
and a lot of that kind of drug tracking stuff has always taken place by, the incentives to do it are the greatest with the companies and with at the federal government level. I mean, adverse event reporting in the drug industry has been a really big thing for a long, long time. But and in general reporting, but it doesn't. There's always been holes in it, and when people aren't testing and people are, oh, I know I have COVID, I can't smell anything, but I don't feel that bad. I'm sure there's people that aren't, being reported as COVID illnesses. Yes.
Well, our daughter went through COVID, been over a year ago, and then resulting things happening after that with a lot of pain, lower back pain, and going to emergency rooms and identifying lots of random things that ended up not being, going to Mayo several times, and all these doctor visits and testing and all of that. And they just kind of finally said, I'm sitting there at the last meeting, and the doctor saying, COVID's, writing chapter 3, we're on chapter 2. So they're saying this is probably an effect of COVID, the swelling that you're having. So now she's taking these nerve blockers, waiting to just see what happens with all of this stuff that's going on. So there's no answers. So it's just kind of an effect that's kind of the unknown. And even at Mayo, they couldn't give us answers on that.
No, I like that statement of, writing chapter 3 and, we're on chapter 2. And that's, pandemics are like that. We haven't dealt with a pandemic, before. But I recall, I was never a good student of history when I was in like high school and college. I was a math major because I didn't have to write papers and read a lot of stuff. But I really grew to like history later on in life, and part of it was when I did some of the epidemiology classes that I did. There were some really cool historical cases that we looked at, and there's stuff that I studied back then, which was last century. We're talking like 1995. We're looking at as the historians of this do have a better understanding, I think, of like what the progression may be like. But we have a lot more tools now than we did then also to help with different things. But, you know, I don't know. It's
Yeah. It's tough because we don't know all the side effects, we don't know all the weird, and when a virus damages some organ or part of your body, you don't know all the side effects that can happen from that. Some people are having the virus in their bodies for extended periods of time, and some people just have long COVID from damage to certain parts of their body, even though the virus is gone.
Does it tend, the deaths seem to affect people who have more autoimmune problems and, you know, so,
Yeah,
I mean,
like,
so healthy people tend to say, oh, I don't need the vaccine because I'm not gonna die from it.
I know in the news recently, Colin Powell died. He had something called multiple myeloma, which affects the B cells, which are the things that make antibodies. So he got the vaccine, but the cells that make antibodies aren't very good at it. And so even while vaccinated, he wasn't protected as much as he could have been.
and you know, and he was actually, if I understood right, due to get a booster, or looking at getting a booster or something like that. But it's like, you know, there is that, you know, trying to protect the people that can't be protected for different reasons.
They don't seem to care about that, you know, it's just everybody else's freedoms and stuff.
Yeah, that's a piece that gets, you know, it does get a little, it gets challenging for me. You know, when I am hearing that kind of discussion and talk, I mean, with regards to, I heard a quote from David Brooks, who writes for the New York Times. He's more kind of, you know, on the spectrum of conservative, progressive, liberal. He's more conservative in ways, but he said, you know, some things are matters of individual liberty, like who you vote for, or how you should dress, or how you want to dress, you know. But some things are matters of communal health and safety, like a stop sign, like a vaccine, and you know, and it's, you know, and I think we're kind of we're not looking at it that way collectively. It's, to me, it gets disappointing when that happens. You know, because he kind of went on to, in talking about that, he was talking about vaccine mandates a little bit. I've decided to involve myself with a vaccine mandate discussion on campus in early November with another colleague to discuss the potential immorality of vaccine mandates. You know, he was saying how vaccine mandates can really work because it's not so much, it's more that people are vaccine hesitant for different reasons, not so much that they're necessarily ardent anti-vaxxers or haters or things like that, but that they can work at encouraging people to get vaccinated. And he gave the example of United Airlines, 67,000 employees, vaccine mandate in place. Now they have 232 that didn't get vaccinated. You know,
232 people?
232 people out of 67,000.
Okay.
You know, and the thing with, you know, I mean, we're all familiar with carrot and stick kind of stuff, right? You know, I mean, you know, people are getting money for getting vaccinated. I mean, there's a lot of people that got vaccinated because they just wanted to, like, as soon as it was available. But there's other people that needed, you know, some sort of, you know, carrot, and now maybe a stick is more appropriate on some level, you know, to encourage people to do it. And not going to get everybody, but that's not, you know, that's not really the ultimate goal, is to get everybody. It's to get more people, because the more people that are, you know, vaccinated, the less likely you get through all the Swiss cheese. And
The smaller the cheese holes.
yeah, exactly. You know, good way of putting it.
So mandating vaccination seems fairly extreme, but I want to say here. Describing, we mentioned earlier, or one of you mentioned earlier, the amount of people who had, and it was very rare, but who had clotting issues. And I can't remember the numbers, but when it first came out, it was something like, 6 people out of 6 million got clotting issues. Well, that's 1 out of 1 million. So taking that into consideration, but how many would have died from the virus had they not gotten the shot was probably way more than 1 out of 1 million.
But the
So-
media focuses on that.
They
those 6
focus-
people.
Right. So how can we bring it back
Social
to,
media more than,
Yeah.
but how can you bring it back more to examining those two statistics and saying, okay, it's 1 out of 1 million people who have clotting issues, and I think maybe 1 out of 6 die. I can't remember the specifics. But then, how many people who get the virus will die? You know, it's much higher. And I don't know how to push facts in the media like that.
Yeah, I found a good statistic that talks about the myocarditis piece, which is the other kind of side effect we've heard about from vaccines, and that's not just the J&J one is the one that's been associated with the clotting issues, and then the other two vaccines are more associated with myocarditis, particularly in young males who are presumably less likely to get severe COVID, but they estimate that per million doses of COVID vaccine, you could prevent 11,000 cases of COVID, 138 ICU admissions, and 6 deaths. But in that same million people, you would only get 30 to 40 myocarditis and 0 deaths. So you're more likely to be admitted to the ICU with COVID than you are to get a side effect of the vaccine, but I think that when you see an example, and I mean, anecdotes are really strong. You see a story, you see a person, that feels a lot realer than numbers do. And I've read that when talking to people and convincing people, it's not the statistics that are necessarily going to convince them. It's more of the empathy and the kind of personal connection, conversation, and stories that can help. That said, I don't necessarily know how to do that at a wide scale, but.
No, and you really, it's, if somebody is ardently opposed to it, I don't care what you're talking about. You know, I'm not gonna convince Mike to become a Bears fan. That's just not gonna happen, right? It's really difficult to change those kind of minds. But I don't think that number of people that are in that boat is nearly as high as we sometimes feel like it is. I think there are far more that are people that are just hesitant or just don't know, good information. And that's where the language of, talk to your provider becomes really important. And I know there's some providers that have a different viewpoint than I do on some of these things, but even locally, the vast majority of the providers are very much on board with, the importance of vaccinations, and definitely the importance of vaccinations over, other heroic treatments, to keep on, sitting in a medical staff meeting not too long ago where, they made the decision to not keep certain other drugs on the hospital formulary that were expensive to keep, have not a long shelf life, that, if we needed to use those for patients that are coming through the hospital, that, we should just be getting more people vaccinated. We can get those things, we can get them from other hospitals if we need them, but for us to spend the money to have it in the hospital, probably to be thrown away if we don't get to using it, these are kind of some cost benefit kind of things that you have to think about and work on.
So people that might be against vaccines would they accept getting a treatment if they got COVID and take a pill or whatever to help them not be in the hospital? I mean, is that,
I think the,
so
most
I don't
of
know
the
what the
people.
difference would be
Yeah,
there.
I don't know. I mean, talking, again, this is anecdotal, but talking to friends of mine that have gone through some of the more heroic kind of thing, treatments, I'm talking locally,
Mhm.
right? That have been admitted and had to go through, qualifying for remdesivir and all the other things that they're all on board with having all of that done.
Hmm.
And they're very, very thankful that there were, that those measures existed to help them. But sometimes there's still a disconnect about how this could have been avoided,
Mhm. Has it become somewhat political?
I think very much so. Yeah, I think it's been, very,
You see videos, I have in the past, of military inductees, heading into basic training and everything. You don't get asked if you wanna get vaccinated. Everybody right down the line.
Yeah.
I don't think a vaccine mandate is asking too much at all. It's, just look at the history of what vaccines have done to our health in our country and how safe these vaccines have proven to be over the last year and a half, or not quite that long, I guess, since
Sure.
they came out. And I think it's just a matter of lack of concern for your neighbors, what I think it is.
Yeah, I think there's a lot of, there's a lot of not good information that people are getting. I mean, there's people that I've, talked to, more one-on-one that I think I've opened their eyes a little bit to it, but, that's 3 hours later. And it's, and to your point, this is a list of of just different viruses that can affect the body in all sorts of different ways. And I didn't have time to go through and cross off the ones that we have vaccines for. But, there's a lot of stuff up here that we now have vaccines for that, it's not about the deaths, you get inoculated for these things because it does reduce morbidity in a lot of different ways.
Mhm.
Kristen, do you have a
Yeah.
question?
People are still talking about herd immunity. Can you touch on that a little bit?
Well, I was gonna bring that up too. There was a really interesting piece on NPR this morning about herd immunity and using Iran as an example.
Really?
And they actually stopped the protective layers, the Swiss cheese layers, hoping for herd immunity. And people are getting multiple infections, lots of virus variants. It doesn't work. And that was a very interesting article. If you didn't have a chance to listen to that one, it was really interesting.
Yeah, herd immunity, based on what I've read so far, we've never successfully gotten herd immunity without a vaccine because the disease keeps spreading, it can change, and especially with diseases that have, mortality rates or long morbidities, it doesn't work unless we have a really good vaccine, and it only works if we have a good vaccine that is taken by many people. And one of the other issues that we're now running into is herd immunity works when an infected person, everyone else they interact with is vaccinated, therefore they're a dead end for that virus. And as this virus keeps changing and now we have the Delta variant, it is more infectious, meaning each person that is sick can get more people around them sick. With that, you need even more people to be vaccinated. So we threw out 70% early on in this pandemic as kind of a good threshold to try to get herd immunity and stop transmission. But with the Delta variant, it seems like it might need to be higher than that. And the key thing about any variant is if we lower transmission rates, we're stopping the evolution of this virus. And that is one of the key things we need to be doing because currently our vaccines all still work really well against the Delta variant. So being vaccinated, these different variants, your immune system still recognizes them all and can still get rid of them pretty quickly, but that might not always be the case if this virus is able to keep changing at the rate it is, because we're having so many infections.
How many variants do we know of right now?
There have been a handful that have been called kind of major concern variants, but there are thousands that have been, kind of, we look at the little genome of them and sequence them, and so people have done studies to see exactly how many changes are happening in the viruses, but then when one becomes more infectious, it's able to kind of outcompete all the other ones, kind of a survival of the fittest thing. And so those are the major ones that are of concern, but there are some people doing cool studies, getting samples from lots of places and seeing all the tiny little changes, and they can track how the virus was spreading based on those tiny little changes and say, oh, one person went from here to there, got that town sick, and that's why that town has all this specific type of virus, versus this other town nearby got it from Madison versus Green
How
Bay or
frequently
something.
do they look at that?
So it depends on, like, someone might do a study of, you know, a certain town or area, and do, you know, a couple thousand samples, but the local health departments aren't able to do that kind of stuff, so
It's not
that's
being
what's
done
hard.
at as high a rate as
Yeah,
one would think. I mean, you're making the assumption that, you know, a lot of people that are getting sick and maybe who they're getting it sick from is Delta, because that's what you're seeing. But that's the way a lot of medicine takes place, in all honesty. I mean, they don't, you know, you often get treated and given antibiotics based on, you know, what they call empiric therapy. You know, they're looking at you, they're seeing what symptoms you have, what other people are having right now, and then they send you home on antibiotics. They don't wait, you know, 3 days for a culture to then give you the antibiotics, right? They might call you and say, hey, we got something else, let's modify the antibiotic. You know, but they're, you know, you don't always know exactly what it is. And so we'd like to know more from you know, to get a better sense of it. I mean, Delta, my understanding is that it came from, you know, developed in India during a time when there was a very, very low vaccination rate. They could have vaccinated a lot more people, but they did not. And they had a very low vaccination rate for many reasons. A lot of people getting sick, a lot of transmissibility. You get a population of, you know, 1.4 billion people that has a low vaccination rate. That's a nice little petri dish to kind of, you know, create a lot of variants, and then a Delta comes out and, you know, makes its way around the world. You know, I think this is a wave, what's happening here locally. This is not going to be where we are in a year's time for sure, but even in several months' time, this is going to appear like a blip, you know, I think, in the big picture. And I think, you know, listening to Ashish Jha, who's the head of Brown University's School of Public Health, I mean, he really feels like the worst is, you know, behind us, and I'm hopeful that he's correct on that. But, you know, variants will happen, variants can happen. I can pull up another, you know, slide real quick. You know, you've heard about the R0 stuff, and so R0 refers to the infectivity of an agent. So if, you know, in essence, like if you have, if the R0 is 1, what that means is that one person can give it to one person, can give it to one person, and when you go through 10 rounds, you end up with 10 people, right? So it's the average number of people every infected person will transmit the virus to, and this is an important piece here, assuming a completely susceptible population. Meaning that we can adjust our knots based on behavior on some level, you know, by having a higher vaccinated population, by, you know, reducing the spread in different areas. We can modify those things. This is a lot of the reasons that we shut everything down the way we did, when we did, was because a lot of this was not known, right? And so if the R0 is 2, then it creates
you know, you can see end up with this exponential kind of situation as you move through generations. So this next slide kind of points to some comparative R-naughts of different illnesses. And when you highlight, this is the initial SARS-CoV-2, okay? We were looking at something in the 2 to 3 range of the way that that was working. But the Delta variant slips in right up here in the 6 to 7 range, and this is a lot less infectious than the measles, which is a good thing. You know, as infectious, close to what smallpox was like. But is it possible that another variant can develop that can be up in that range? Sure, it's possible, but there's things that can be done as, you know, as a population to kind of reduce some of that, you know. And this is that, you know, debate of, you know, should we be giving boosters when there's people in other parts of the world that don't have, you know, that aren't vaccinated at all, and, you know, and can we, you know, get the vaccines to them so that if they're vaccinated, then it reduces the, you know, it is an ecosystem. Like I said, I'm not an ecologist. I'm a guy who studied math and went to med school and stuff. But I have been sold on the ideas of many of my ecologist colleagues on how the interconnectedness works.
I have read that we're at 40-some% of the world
Yeah.
has gotten at least one vaccine. So we're at 3-point-something billion people. So
And we are
getting there.
I mean, and we're as a nation, you know, rather privileged that, you know, pretty soon anybody that wants to get a booster is fully vaccinated. I mean, if you want to get vaccinated, you know, tomorrow, you know, if you're not vaccinated, you can find a place to get vaccinated immediately, right? If you want to get a booster tomorrow, I guarantee there's probably a place you can get a booster tomorrow. Only because there's vials being cracked open and they're throwing stuff away. So we are in that place where we are throwing our vaccine away, you know, pretty much daily around here. And it is unfortunate, but we've all learned what supply chains are in the last year also, you know, and how it is to kind of, you know, unfortunately I can't like grab that vaccine and hop on my private jet and take it to family in India or anything like that. You know, that's not an option. So. Any last questions? Any last thoughts? Do you have anything you wanted to add, Lauren?
There's a question back here.
Oh, yes, please.
I read a CDC study of a Delta outbreak in a Texas prison.
Okay.
It ended up that 93% of the unvaccinated patients got COVID, and 70% of the vaccinated inmates got COVID. Do you have any comment on that essentially real-world efficacy of the vaccine versus the tested one? I mean, is it just because of the R-naught of Delta? Is it just because it's a basically perfect environment for an outbreak? Or was there something lacking in the initial studies of the efficacy?
Or with the 70 versus 93, was there a variation in severity?
Yes, but I'm just talking about
Yeah.
Infection.
straight infection.
I remember hearing that in the news, and so severity is a difference, but the other thing I think is, as you said, I think it's the perfect scenario of a bunch of people in a very small space with no mitigation efforts, I'm assuming, to, you know, keep people who are sick away from other people, no masking, and being kept in, you know, close quarters, because the efficacy that we're talking about with the numbers as far as like 95%, I don't know that that counts, that would take into account if your roommate is sick and you see them every single day.
Yeah, so is it like
95%.
Is it 50 minutes of exposure? Is it half an hour of exposure? What is that 95?
The 95 comes from when they vaccinated people, 95% of them never got sick in the, how long did they do it? 4 to 6 months, I think, of the study before they got enough data, and each of those studies came out of 30 to 40,000 people for the
Those
Pfizer.
are just
and
normal
Moderna.
day-to-day interactions.
Yes, so it's day-to-day interactions, and so people interacting with someone who's sick, maybe it's someone you live with and you get exposed many times, but maybe it's just, a short interaction from going
Right,
to
so
a restaurant.
95% effective, but cumulative
Yes.
exposure would drop that, obviously.
Yeah, so I think it's the cumulative exposure that really
Okay.
changed that. And we did see some protection with the vaccine, the 70%
Well,
versus
right,
the
obviously,
90, but
it's not,
yes,
not
it's
95%.
it's definitely a
Yeah.
different situation.
Yeah.
Yeah, like in my world of animals and vaccinations, the vaccine companies do challenge studies. Like, we vaccinate a group of calves for bovine respiratory syncytial virus, and then 3 weeks later, you give them bovine respiratory syncytial virus, and you see how many of them die and how many of them don't. And that's how your vaccine works, but with people, we don't.
I
we
think
don't
there's
do
some
those. We
ethical
don't do
issues
those.
with
Yeah. But it makes it much, it makes it much more clear.
I could offer extra credit and maybe some students would volunteer.
Maybe
but,
that might be the carrot, though, or the stick.
yeah.
Yeah.
I mean, and I would even add to, I heard the report about the Texas prison. It's an interesting one. I didn't read the specifics on it, but what vaccine, when was the dosing, how much waning may have happened in that time.
There was some difference of 4 to 6 months versus less than 4 months versus out of 6 months, but it wasn't a major
Sure, okay,
component.
yeah.
Well, I think in the school system, with someone that we know that was vaccinated, wearing masks in school, but again, it's that environment you're in
Yeah.
that small space, and they got it. I mean, it wasn't severe, but still, a couple in their family got it. So it's possible,
Yeah,
but.
no, it is, and that's where, I think, where the mask wearing when you're bringing the kids together in the space is not a bad idea, just to kind of reduce some of those things. I mean, I know that there's, some different, concerns about some of those things, but it's working okay for us at the university. I think that, people have to wear masks in the building, I'll be honest, I'm tired of having to be the police for that sort of thing. And I don't want to interfere with a student's learning by telling them to constantly, do, adjustment mask or do things like that. But, there was that period where, here in Lancaster, where, masks were, they made the decision to mandate them for a little while, and then they created a matrix that allowed for different optional scenarios, which is where they are in some places. And it's it's difficult. These are hard decisions. Lauren's in Iowa.
Yeah, everyone has different rules there, but I mean, it's just, it's a lot of choices. You have to figure out what can you do to make you and your family safer. And I mean, I have a 4-month-old son, and so when I was pregnant, I did lots of reading to try to decide if I wanted to get vaccinated, and I did, because I thought if I could give my son protection when he was born, it would be better than not, because he won't get vaccinated anytime soon probably, and obviously can't wear a mask, but everyone has to figure out what their comfort levels, what they can do to keep themselves safe, and then everyone else around them, which is the other piece that is important.
So I'm hearing a lot of anecdotal evidence brought to me that in Iowa they have less rates of positivity compared to Wisconsin, blah, blah,
Yeah.
blah.
No,
I mean, it's just,
the difficulty is getting tested is difficult. So my husband works in a school system, and very few people are getting tested, and there is no quarantining, that's not, so even if you are a contact of someone who tests positive, you don't have to quarantine. And they've definitely had decent rates of people actually testing positive, students testing positive in their schools, but they have no mitigation efforts, I guess, this year. So
I mean, it's
far.
frustrating because, you know, you want to be on the same page about certain things like testing, and when people are, for very different reasons, playing by very different rules, it becomes, you know, because priorities are different, and, you know, I mean, this was, you know, this is anecdotal, but it's personal anecdotal, where, you know, testing, or positive cases show up on a high school team here in town. Going to quarantine for 2 weeks. This was last spring. They go into quarantine for 2 weeks. You know, I being me, I'm like, my son is on the team. I'm like, let's get tested. You know, so take him to get tested. After 4 days, take him to get tested again. He's negative, but his circle is extremely small, right? He doesn't really have a lot of people that he's hanging out with, and you know, and apart and outside of the practice setting, you know, when he was in practice there. But, you know, it was known that I tested him, but it was also known, it became known to me after the fact that the rest of the team, nobody even really got tested, right? Only the people that were sick went and got tested. And on returning, he was kind of encouraged not to practice with a certain part of the team because he was getting tested, and because he was getting tested, there was a risk that he may be positive, and then in doing so, that would shut down the rest of the season. So
Compared to the other students who weren't even getting tested?
But we're tested.
Exactly.
That's ignorance is bliss.
No, it is very much that, and
Yeah.
it was a very frustrating moment for my son, you know, who, you know, was sitting with the varsity team and not necessarily playing a lot, but now he's not even allowed to sit with them, you know. And so, you know, so there's things like that are happening like that culturally that are prioritizing certain things, and I find it very frustrating.
Me too.
You know, and it's, you know, so, yeah, so, I don't know, I could go on forever.
I just can't grasp the mindset on those kind of decisions. People who make those kind of decisions, I don't know, have no idea where they're coming from.
It is very much a ignorance is bliss kind of thing, and you know, but at the crux of it, you know, I think is a situation where there is this is just like the flu. This is not a big deal, and I'm not saying that it's a big deal for every single person, because there's a lot of people that we all know who got sick, and it didn't impact them in a huge way. But I think in recent times, I'd be surprised if there isn't a person locally who doesn't know somebody who got really sick or even died. And, you know, when I look at the obituaries, you know, and when I talk to different, you know, families, it's becoming apparent that there are, you know, for the size of our population, that there are so many people that are dying from COVID is very sad.
Exactly.
You know, and I don't really understand why. I mean, going into this, I remember feeling like we were uniquely positioned because of where we're located to be well protected. Because, I mean, living in Lancaster is like living on a cul-de-sac that nobody goes to. You know, it's like, you know, you just don't, you're either intending to go there or you're lost. Right? You know,
It's not a crossroads.
When I show people where I moved to, you kind of zoom in on Google Earth, and there's the closest interstate's an hour and a half away. You know, none of my friends want to come here because they don't want to drive for an hour and a half not on interstate, right? Mm-hmm. You know, it's but it's also, it's what makes the driftless too, right? And so it's not necessarily, I'm not saying that's a bad thing, but, you know, because of that, you know, the traffic going through here, there were the possibility of, you know, contrast of spread, we were originally slated to go to a wedding in Chicago yesterday of a good friend, and we decided, against it for a few reasons, but COVID was a factor on some level. I just, didn't feel, my mom would have gone with us, she's 81, and I, haven't gotten her booster yet, and I was like, yeah, let's just not go.
Well, I get frustrated with it because I do have a blood disease.
Okay.
And I'm on, like 4 cancer pills every day, and it says right on the bottle that they probably will not work with any, or vaccines will not work with the pills.
Sure.
So I mean, I always get my flu shot, and I got the vaccines, and I've already had the booster. But just like cold pollen, you don't know. So I don't want to be hibernated forever because
Right.
people are not getting, I mean, we have never spent a holiday with our kids since any of this started. But, you keep thinking it's gonna get done. And so I don't go to these meetings where everybody votes and that, because a lot of us don't want to be around the crowds. So it looks like the huge majority, because we know enough to stay home, because we could catch something, and it's just like never ending, because the people are, unless you just line them up and say you have to get the shot, I don't think they're gonna get the shot.
Yeah, that's unfortunate. I mean, I think we are moving towards endemic, so the difference between pandemic, epidemic, and endemic, pan is kind of world or global, right? Epidemic is the spike,
Yeah.
which I'd say Delta is more, while it's a pandemic, it's also like locally an epidemic. And endemic is, a certain amount that is always going to be there, but may not be being spread as much because it's very localized. There are a lot of vaccinated or immune individuals around that may not be, that may limit the spread in different ways. There's a lot of disease, like flu tends to have, endemic, rates, but then we have like these potentially annual flu epidemics, especially if there aren't as many people that are vaccinated. But you saw the R naught for flu, it's pretty low comparatively. And we don't always give vaccines and do medications and stuff just to prevent like death and morbidity. Sometimes we, do it because we want to go to work, because you need it. How many times have you popped a couple ibuprofen just to get through the next, few hours of work, and then, rest later, that's another way things.
If I can get kind of specific with you, if you go back to the slide that showed the proteins or whatever there,
This is you, Lauren.
Yeah, there we go, okay. So when we talk about COVID causing lung damage, so what are those protein, I'm kind of focused on the protein. Is there something like a buildup of protein in the lungs, or what's happening, with the problem with the lungs and COVID?
I believe it's, each time a virus infects a cell, it can kill that individual cell and then go to the neighboring cells and infect it and kill them. And then, depending on how many viruses are there and how many cells they've killed, you can get more severe lung damage. Some people also get subsequent like pneumonia from bacteria or something else because your lungs were weakened by the first infection. But I don't know.
Do you remember what cell it is? We'll finish you.
It's just the lung epithelium. I thought like it's.
Is it the epithelium?
It's the whole airway. Everything has the receptor that the virus sticks to, basically.
And
Your whole nose, throat.
coronaviruses in general have the ability to destroy the system in your lungs and especially in your upper airway that are constantly cleaning out.
Yeah.
So it's goblet cells that produce the normal
Sure.
mucin and the epithelial cells your body is exposed to constantly bacteria, viruses, fungus, and your lungs are clearing that out, and the coronaviruses, whether it's common cold or COVID, destroys that apparatus, so then the fluid accumulates, and all those other things can accumulate then too.
Yeah, I haven't heard specifically of a buildup of protein in lung damage, but
Yeah, I mean, epithelium, fancy word, just means cells on the surface. And as you go down your respiratory tract, like everything from mouth all the way down to the ends of the lungs, the epithelium changes, and it changes functionally based on it changes based on what the function in the different areas is. You get to the distal or the end parts of it, it's like a thin t-shirt where air can oxygen and carbon dioxide can pass. But as Sally was saying, in those upper areas, it's almost like it's fly paper with little like moving fingers that are there that are trapping particles and moving it up in your respiratory tract, where you can then spit it out or swallow it or something. And like smokers have an issue where it actually causes damage to the upper respiratory tract bit and decreases motility of some of these little moving spirit fingers, I'll call them, cilia is what they are. But it keeps them, so smokers, that's why they get that cough, right? It is because they accumulate more mucus, it doesn't get out of there very well. But so if like this has the potential of damaging, different parts of that respiratory tract, and in doing so predisposes you to other infections, right? You pick up the pneumonia after you've had a virus. That's not an uncommon thing, right? Somebody gets like a really bad bronchitis, and that turns into a pneumonia because their immunity is suppressed from the illness. So yeah, I haven't. I'm teaching histology next semester. I hope to do a little bit more research to kind of dive into some of this stuff, but I have bandwidth issues. Well, thank you very much.
Yeah, thank you for being here.
Yeah, no.
Thank you.
We need to record the applause for the end of every class.
yeah.
So, we'll play that.
I normally